You don't know me. Probably never will.
But I need you to do something for me.
Something that could literally
change everything.
You'll never get a thank you card.
And yet, I need you to do it.
And if that weren't enough, I need you to do it as soon as you are able to.
If you do this for me,
I'll do it for you.
And for every single person you love.
Deal?
This is our shot to leave COVID behind.
Hello, everyone. Welcome to the third session, Improving Maternal and Infant Health through the DC Prenatal Quality Collaborative. I will turn over to the presenters and they will begin.
Good afternoon and welcome. We're really excited to be a part of this program. Let me just share my screen here. The DC Perinatal Quality Collaborative, as many of you may know, was formed in just a year and a half or so ago, really at the request of information that was received from DC Health, from stakeholders, from what they were seeing in the field and what several folks around the city had identified as a need to focus on perinatal quality in a collaborative fashion throughout the district to address maternal morbidity and mortality, among other things. To that end, as an update, for those of you who may not have been on this journey since the time that the collaborative was formally created, the district put out an RFP to form the collaborative with a mission of serving as the district's champion for reducing maternal morbidity and mortality and improving health outcomes and narrowing race and place-based disparities in maternal health. One of the key components of this is this last piece of the statement, using a data-driven quality improvement approach. The way quality collaboratives are set up in this field throughout the country, there is a real emphasis on using a data-driven and quality improvement approach to make sure that we're driving towards not only achieving outcomes, but using informed information to make sure we're making decisions on the right activities to pursue and focus. The full collaborative includes a broad representation of stakeholders. It includes hospitals, FQHCs, community-based programs, government agencies, patient and family representatives, a wide variety of stakeholders across the district. And the groups, after we got through some of the initial sort of infrastructure building, formed a more formal sort of vision and goals. So you can see the connection to that concept of data and driving measurable improvement in the vision. You can also see a nod to sort of what do we envision this future will look like, and something in terms of making sure that women are thriving, being strong, and able to have healthy pregnancies. So it's a bit about reducing morbidity and mortality, but also around sort of what those positive outcomes could look like. To that end, the group also set two sort of high-level overarching goals, one of which focused around this idea of reducing morbidity and mortality or co-occurring conditions and death. And you notice here there's a few places where they really emphasize the importance of those race and place-based disparities. If you look at the data for the district, women of color in wards 7 and 8, particularly non-Hispanic women, are much more impacted by this as an issue. The disparities are stark in contrast to what we see for other race and ethnicity groups and in other wards in the city. To that end, the group also felt it was really critical and important to call it a second goal, specifically looking at reducing systemic racism as part of what they were looking at to decrease these disparities that we're seeing in relation to maternal morbidity and mortality. So really gave a nod to that as an issue in the district, as something that needed to be called out in a separate goal for the group, and is a large focus of some of the initial activities of the group and will continue to be. The group itself is formed of the full committee. I mentioned some of these stakeholders. This gives you a sense of all of those who are potentially involved. And as part of that full committee, since it is such a large group, 45 to 50 individuals serve to represent all of these different stakeholders. There is an advisory board that includes a representative smaller group of these stakeholders to really sort of drive the decisions, take the information that is gathered from the data, from participants in the full collaborative, and from other mechanisms to make informed decisions for the group. And the communication cycle within these is really sort of circular. So we get information from the committee and stakeholders and bring it to the board. The board has discussion, and some of that goes back to the committees and sort of around, so that we're making sure that we're really taking into account input from the various groups. There's also a patient family action network that was initially formed as part of the early work and will be developed further going forward. As we're getting into the real sort of heart of the work on quality improvement, there is clinical implementation work groups. You'll hear me talk about this group called AIM. That's the Alliance for Innovation on Maternal Health. And there's really a lot of work that we're doing in conjunction with this nationally available network that has a lot of best practices. I'll talk a little bit more about that in a minute. The group also formed a data work group to make sure that we've got the right support to make sure that we're keeping our eye on that data and our progress and are staying on track. There is an administrative team that supports the entire collaborative. And then as part of this work, one of the things the collaborative identified was that there may be times where we need to pull together task forces or groups that might last for a short period of time to address certain issues and then might sunset and others might come in their place. And I'll talk a little bit about one that's already been formed in a moment. In terms of timelines, just to give you a sense for where has the collaborative been since perhaps last you heard of such a thing, or if you're just starting now. Back in September of 2020, the group actually sort of crafted recruitment materials, if you will, information that sort of shared with potential stakeholders what we were all about, and worked on gathering those stakeholders to be part of the collaborative. We actually convened the first set of stakeholders in October of 2020. And have met regularly with all of the groups I identified on the prior slide since that time. But even during COVID times, folks have been very interested in moving this work forward and extremely engaged, and were able to pull together last fall. As I mentioned, we had a full committee meeting in the fall, and the group has been meeting since then to work towards choosing what we wanted to tackle first, making sure we're clear on what those collective vision and goals might be, and to sort of move the work of the collaborative forward. In February of 2021, the group sent in its AIM enrollment form. This Alliance for Innovation on Maternal Health, or AIM, has 2 times a year where you're sort of able to enroll in their activity, the fall and the spring. And so we were on track to be in their spring cohort. And the group really sort of is designed to help perinatal quality collaboratives do the lifts on quality improvement activities based on experience from other quality collaboratives and best practices. They provide resources and materials and a lot of support for collaboratives to achieve success. Following that, the acceptance into AIM and refining those goals and ensuring that we were doing all of the things that we need to make sure that the stage was set, if you will, to actually start the meat of the work. In terms of what happened once we enrolled, identification and development of supporting materials, in particular based on local needs. I think every jurisdiction probably thinks they're special, but we in DC all know that we are. Being a city that's sometimes treated as a state and sometimes not, and having a really strong community, there are some needs that we identified from a local perspective that the group really thought were important to address. Additional work that happened was creating for what we call bundle kickoff. So AIM has what they call bundles, which are essentially sort of, think of it as best practices and guidelines that hospitals should follow in order to provide the best possible care. So pulling together the work that needed to be done for that, doing a kickoff, making sure that experts were available as a resource to sort of walk us through how we would proceed with these activities. Was part of what happened this summer. And then the full collaborative identified the need for what they call a mapping task force. So as part of this work, the bundles themselves really focus a lot on sort of the narrow portion of a person's experience when they're in the hospital. And the group really identified early on that there's so much more that goes on all sides of that, outside the walls of the hospital, that are needed to support real improvement for any topic that we would choose to address or any disease state that we would choose to address. And so they recommended that we form what we call the mapping task force to really dig into some of those other things that we might need to pay attention to, identify gaps, identify where there may be services that were not being leveraged or where services were not available, and the like. And so that group was formed over the summer and is completing their work shortly. In addition, where we're going sort of next, if you want to think about the fall, is actually beginning implementation of the data collection process and implementation of the bundles. In fact, that has started over the past several weeks. The hospitals have started evaluating their current state. It's been really nice to see that a lot of the activities that need to happen as part of the first bundle that they chose are in place. So we're in a point of sort of figuring out where there may be gaps and other activities that may be needed, or where we might be able to improve in terms of what's been implemented. As I mentioned earlier, also expanding patient and family involvement. The folks who have been involved thus far have been instrumental in keeping us grounded. As providers, and for me as an association representative, it's easy to get caught up in the work and the science of it all. And these folks have really been fantastic in helping to make sure we're staying grounded and really staying on track. And then in 2022, we'll do what we call quality improvement cycles, continue looking at ways that we can improve on the bundle that was selected, expand data capabilities, and do some clinical education. A big component of that is actually health equity training and some activities around that health equity training. I mentioned the bundles, just to give you a sense. The first bundle that the collaborative chose to address was the hypertension bundle. AIM has several bundles based on disease states, cardiac hypertension, hemorrhage, all things that someone could experience as part of their health, both during pregnancy and otherwise. And they chose this one based on the data that was available. Looking at hypertension rates in the city, both as comorbidities and as contributing factors to mortality, and at some of the cardiac issues that could be an extension of hypertension. The group felt that this really was the most critical activity to tackle first, or disease state to tackle first, if you will. In terms of that, just so you get a sense for what does this mean, really the bundle provides guidance to hospitals around what the best practices are for standardizing care. Participation in this group allows hospitals and others in the stakeholder group to learn and share information and resources with peers across the district as well as nationally, access subject matter experts, and really have a structured mechanism to track, support, and make sure that they're actually continuing to drive towards improvement. So there's an accountability component. Just to give you a sense of sort of what a bundle includes, readiness, identifying where you are, recognition and prevention, how you then respond once you recognize an issue in terms of actual delivery of clinical care, reporting and learning. And the way AIM was structured before, they had a separate bundle, if you will, to address race-based disparities. And they determined that, that's something that's sort of pervasive across everything that we do, sadly, but that they really needed to incorporate that as, sort of, if you want to think of it as a fifth R within each of the bundles. So they are adding as well a component within their hypertension bundle on that. Our group felt that they don't need to wait for a national group to come up with that. We're looking to the existing bundle that they have, and then to the expertise that we're able to pull together to address that, since that was a critical issue for our work in the district. I mentioned the mapping task force. I wanted to give folks a sense of what this group is working on. So they really have gotten together and sort of identified, as they were brainstorming on where issues were, some key areas: social determinants of health, addressing racism, quality from a broader perspective, co-occurring conditions, access to care, systems, and even health literacy. How are we communicating, and are we communicating in a way that sort of makes sense to the individuals that are receiving care? As part of this exercise, they did sort of a mapping, identifying those areas. What are the risks? What's the gaps, and why might those be? With the idea being, as they move forward, that they're able to recommend to the collaborative where other activities may need to be happening to support both improvement in the area of hypertension and also in other bundles as we go forward. The way we've designed this, enough of hearing from me and talking at you. We have a panel of experts who have been working with us on the collaborative to sort of do a little Q&A with me. Just as a quick introduction, didn't introduce myself to begin with, but I am Gayle Hurt. I'm the AVP for Patient Safety and Quality Operations at the District of Columbia Hospital Association. And in this work, I serve as the Executive Program Director for the Perinatal Quality Collaborative. Today, I'm joined by Yolette Gray, who's the Senior Manager for Public Policy and Community Engagement at the Hospital Association, and she serves as the Patient Family Partnership Director for the PQC. Lindsay Hindelsman from the Newborn Services Program Manager from DC Health. She's in the Perinatal and Infant Health Division within the Community Health Administration, and is in this instance involved in keeping us on track for this activity and being involved in the work of the PQC. DC Health is the Department of Health for the District of Columbia, which sees the Perinatal Quality Collaborative as a key program to help attain the goals set out in the district's perinatal and infant health strategy. And DC Health funds the DCHA to operationalize the PQC. So Lindsay's instrumental in ensuring that we stay on track there. And we're joined by Dr. Melissa Fries, who's the Director of Genetics and Fetal Medicine at MedStar Washington Hospital Center. In addition, Melissa's to her clinical role, she's the Clinical Executive Director for the PQC. So I'm pleased to be joined by this esteemed group. I'm gonna give them some questions to sort of give us a sense for where we are, where we're going, and what we might be grappling with as we move forward. To that end, we mentioned the importance of stakeholders. We talked about, the involvement of patient and family members and the importance of community groups that are involved. And I'd like to explore a little with my expert panel here. What do you see as the role the community plays in the Perinatal Quality Collaborative? And Yolette, perhaps I'll start with you as our Patient Family Services Director for the PQC. Where do you see the community playing a role in the PQC, and what's so critical about it?
Thank you, Gayle. Thank you so much for that question. And before I get started, let me just say that the role the community plays in the Perinatal Quality Collaborative is crucial to achieving our goals. When I think of the community, I think of the patient. Of course, having that patient voice is so important in the work. For us to have meaningful change, we need to have that patient voice. Their voice is important in the planning, in the execution, also in the evaluation process. The community, however, is not just the patient, of course, it includes the providers. It also includes the resources that you mentioned that are available, resources that are addressing maternal health before, during, and after pregnancy. DC has a lot of resources, but there is a disconnect in the system, in the outcomes. So the role that I see the community plays in the PQC and the role that I'm playing is working together to support moms and families navigate the system and be empowered to advocate for themselves. Thank you again for the question.
Yeah, great. Lindsay, let me move to you next. As DC Health, I know that, the folks in the city, that's why you're here, right? So what do you think about sort of the role that the community plays and how critical it is and what we need to be thinking about from that perspective?
Sure, absolutely. Thanks, Gayle. And yes, similarly to how Yolette put it so well, community feedback, agree, is extremely important. And truly authentic involvement is the best way to understanding the community and patient experience. So that really includes how it impacts utilization of care and how it impacts how care is being provided from the community patient perspective. Without involving the community in collaboratives like the DC Perinatal Quality Collaborative, we can't fully understand that perspective. So from the DC Health viewpoint, encouraging collaboratives like the PQC to have official inconsistent community and patient engagement is vital. So for the PQC, we're pleased that there is patient and community representation. There's a patient advocate representative involved. And the collaborative is going to continue to explore other avenues to engage essential community members and continue to bring the powerful and significant perspective they bring to the group.
Thanks, Lindsay. And Dr. Fries, I think both from perhaps your clinical hat as well as your clinical executive director of the PQC, I can imagine that this idea of sort of those connections that need to be made, to Yolette's point, sort of before, during, and after, are critical, and understanding what matters to the patient are important. So I'm curious about your thoughts on this as well.
I think of the PQC as fundamentally focused on the community. This is not just an arbitrary group of people getting data and trying to work just with a hospital, but really engage with our community. We're fortunate in DC that we're a relatively small group. So we regionally have the capacity to be very much boots on the ground and engaging with all of the community leaders, hospital personnel, medical personnel, and involvement with patients themselves. One of the critical things that I see that we really need to engage with is to bring in the lived experience of our patients so that they can share with us what was their experience when they had a personal role in maternal morbidities or in their family and maternal mortality, heaven forbid. What were the things that they felt were needed? What didn't happen? And how can we as a committee try to bring the recognition of those into the successful engagement for the community? I feel like the community is our real bellwether and understanding our success. What are our failures? What are our real building blocks have to come through the community eye. And so I'm delighted that we have that opportunity within our collaborative at the moment. And I really am grateful to all the patients who are willing to lend their voice to things that they think are vital.
Yeah, thanks. And it's interesting, I sort of mentioned, I think at some point in my prior comments, how those folks have kept us grounded, and something you said sort of reminded me of a reminder that one of our patient and community folks provided for me as we were speaking. It's so easy for me as a quality improvement professional who's not, in the experience of the moment, in terms of experiencing in pregnancy and complications that can happen from that, to get caught up in the numbers, so this is data driven. And so I'm looking at, look at the rate of mortality and look at the percentage of people who are impacted, and then saying, so how might we reduce that? What percentage can we decrease that? And the community members who sort of took a moment to remind myself and a few others who got in that sort of big picture science mind, like there are people behind that number. There are people that matter to their mothers, fathers, daughters, sons, family members, community. And that has been really critical to make sure that we're sort of staying, as I mentioned, sort of grounded in what we're doing. And I think that, expanding the work with those groups is just going to make this work so much better. I'm going to take a moment just to answer a couple of questions that came in the chat that I think are kind of related to this question. One probably came in when I was doing my Q&A about asking about the advisory board membership and sort of who's represented there. And, we have community representative there, community-based organization representative, a patient family representative, hospital representatives, someone from one of the Medicaid MCOs represents that group. DC Health sits in the group. DHCF is invited. We have somebody from DBH. So we've got sort of a broad swath of stakeholders. We tried to really make sure that we had a representative from each of the key critical constituent groups, both provider, community, patient, and government entities, to make sure that we had a really good representation from that group. And then I mentioned that circular communication. We really do a lot of trying to make sure we're meeting with full collaborative members individually to hear their voice, as well as in the full collaborative to make sure that we're getting voices from those folks' colleagues so that they can speak on behalf of the broader group that they're representing on the advisory board. Someone actually asked about a mechanism for looking at value-based care and maternity health and how sort of that is happening. Right now we've had conversations about it, certainly come up. That's part of why we've thought to make those connections with the Medicaid side of the house, as it were. Exactly what that looks like for the city yet, I'm not sure. But I think this is a component that folks have said is sort of key and critical. And including that in sort of the value-based purchasing, value-based care space, I know is something that's part of conversation, and certainly something that could potentially, be relevant to the community in terms of understanding how that accountability mechanism might work. Someone else asked about Healthy Start and some of the other groups. We do have, as I mentioned, all three of the Medicaid MCOs are involved. March of Dimes, somebody mentioned them, is actually involved with us so that we can connect the dots there. And one of the things that we're actually working on in that timeline I showed on expansion is actually to make stronger connections with Healthy Start and make sure that we're doing those connections. And Lindsay and the team over at DC Health are actually helping us a lot there. There are a few questions here I cannot answer, so I'll ask my colleagues to maybe take a look. Some questions around, sort of specifically what DC is doing to protect rights and discrimination, and a few other things in terms of community that I'm not expert enough to answer. And how will the community's voice be quantified? The community's voice is included. We do focus groups. We include them in the conversation when we're having those conversations, and are looking at how we incorporate, as we were talking about addressing, systemic racism, how do we incorporate understanding whether we're actually achieving what we think we're achieving with the work there. And, part of that's going to be looking at whether processes are improved and that kind of thing, and whether outcomes are improved. But part of that is going to be assessing from folks in the community and patients whether or not they're seeing a difference in how they're treated. And that will certainly be done in a both sort of qualitative and quantitative fashion. Let me move to our next question. I'm curious from the panel what you think's gone well so far. Let's hit a couple of the things that we might think. And Lindsay, I know you're newer to supporting this, but maybe I'll hit you first. What have you seen or heard about that's gone well so far?
Sure, thanks, Gayle. I'll focus on the work that's been done around the operation side, the formation of the collaborative. So particularly one of this size and importance is no easy feat. The collaborative was created in response, as Gayle has mentioned, from feedback from the DC provider, community, DC patient, community priorities that were determined within the DC Department of Health. So we're pleased to be where we are today, to be presenting on what's happened so far with PQC. And focusing on building a PQC to help improve health outcomes for women and newborns through continuous quality improvement. So as Gayle shared earlier, DC Health supports the project with the DC Hospital Association as the lead. They've done a truly phenomenal job leading the DC Perinatal Collaborative, including, Gayle has shared all of this, but to reiterate, in what has happened so far, building the infrastructure, applying for the Alliance for Innovation in Maternal Health, as also known as AIM membership, getting subject matter experts a part of the organizational structure, which is very key to the leadership, as well as key clinical implementation champions, and establishing the collaborative charter and data-driven clinical and outcome-related goals and objectives. So, from the DC Health perspective, there's been a lot done so far, and we're really in a great place to take it to the next step of QC.
Thanks. Dr. Fries, let me ask you next, from the provider perspective and someone who's sort of been involved from the beginning. What do you see as some of the things that have gone well so far?
I really have been excited and just tremendously proud of the development of the very diverse and very motivated group that we've had as part of the PQC. It's one of those things where it doesn't seem to be a burden to be asked to be part of it. It seems to be something people are eager to say, can I join? Can I be part of this? How can I communicate and share? And I think that has been, to me, one of the more gratifying experiences, as well as reflecting the fact of, oh yeah, I didn't think about that particular group. Yes, we want you. Yes, we need your engagement. Yes, we want to have all of these thoughts brought to bear. I feel like that has been one of the real benefits. Again, as a small group, we probably know each other within our community and can say, we need someone with this aspect of knowledge. Can we go out and seek them? And then finding them and finding that they too want to join our group. So that has been extraordinarily gratifying, and I thought has gone extremely well. I also have been really very, very impressed with the function of our working groups that we've created. The working group on mapping, the working group on the data collection. That's been aided very much from DC Health in terms of their own data status, but also from DC Hospital Association and other organizations. We've been able to engage knowledge about data, and it's not been stovepiped in a way that we've been limited in that. And then finally, the thing that I thought was really remarkable is that we've had in our group as an intrinsic person, someone who's known about the development of the Alliance for Innovation in Maternal Care from its inception, Ms. Jean Mahoney. And she has been pivotal to get us engaged in AIM and to get us really rolling on our overall hospital engagements for that. I want everyone to recognize the PQC is not just something unique to us here in DC. We're part of a national organization of PQCs that has actually been initially formatted through the CDC. And so there are a lot of groups out there that are trying this and have learned lessons, have said, well, this worked and this didn't work. And that kind of fundamental knowledge has been extraordinarily useful for us to try and move around some of those hazards and remain focused.
Great. Yolette, she talked about sort of the importance of some of those other folks that are working with us and their willingness to work with us. I'm curious sort of your opinions and thoughts about what's gone well so far.
Well, I absolutely agree with Lindsay and Dr. Fries on that. The level of engagement has gone very well. We do have a diverse group of folks that are very passionate about maternal health and infant health and are ready to work together to ensure there is significant improvement in outcomes. Providing, there is an opportunity for learning. There's an opportunity for sharing and making sure that there is changes in the quality of care that we provide. Dr. Fries mentioned the mapping exercise. I am part of that mapping exercise, and the group are doing a marvelous work looking at the resources that exist, the gaps that exist, and how can we address some of those gaps. to inform healthy outcomes for birthing mothers. So bringing these groups together, it has really been an exciting moment. And I'm happy to be part of that work because I can see how everyone wants to be involved and how important this work is to them. So I agree with both of you.
Yeah. It's interesting. I'll add my 2 cents at the end and then move to a tougher question, perhaps. That level of engagement has been amazing for, the Hospital Association runs several collaboratives, and this is one. We never have to worry about people sharing their opinion, being engaged. As I mentioned in my presentation, we were trying to do this lift and COVID hit, and we really didn't break stride. Folks were busy doing what you needed to do to address that issue, but still made the time for this because it was important. And so that's just been fantastic from my perspective as sort of a facilitator of the group. In fact, I think the toughest thing I have to do is, as you pointed out, sort of everyone wants to join, and it's sort of how do we keep the group where we have representation from all the different constituent stakeholder groups, but still sort of a group that's manageable. And one of the things we've really sort of thought about is how do we find other mechanisms so people can share their thoughts and opinions outside of the group so that, the group can still be a manageable size, but we're really able to get some ideas and thoughts from stakeholders that might not be sort of directly involved in the meeting. So that's been really refreshing from my perspective and a great thing. And I hinted a little perhaps at one of the barriers there is, how do we then reach out to folks who are not in the group and how do we get those opinions? I'm curious from our panel's perspective, what do you see as the barriers, either that you've seen so far or that you think, we should be anticipating? And Dr. Fries, I think maybe I'll have you tackle that one first.
Well, I thought a lot about this question, and I have to sort of break it down into some of my fundamental thoughts in terms of where we are. I feel like one of the barriers that we have is the degree of enthusiasm may sort of dilute some of our energies. And I don't want us to fly off in double areas when we really can't put a real focus on that. Having said that, though, I feel like working with our AIM system is going to keep us grounded, at least in the hospital base. And I'll speak a little more to that outside this question. But in the hospital space, I feel like we have a lot of working groups that are already engaged in putting together the AIM requirements and initiating the actions. One of the things that I've learned, though, is that hospitals, birthing hospitals, are not our sole place in the city where patients who are pregnant receive care. And so I feel like we have to also be very inclusive of other sites for pregnancies to deliver that may be in emergency rooms or non-birthing hospitals, and how to engage with them and how to then provide valuable information for them. It has come down when we've looked at some of this. It has to do with some of the development of citywide systems for reaching out and finding high-risk OB care, and also reaching out and finding actual sites for people to get OB care fundamentally. And I think some of these are barriers that will feed into our development of our improvements. We'll realize we can't do this unless we solve this problem first. And that will be something that we'll see as we try to build further into taking these actions.
Makes sense to me. Lindsay, what do you think? Barriers and what are you anticipating? I'm sure DC Health would like us to resolve all of those, but.
Right, exactly. Just figure it all out. Dr. Fries makes, really good points that I won't reiterate, but I completely agree with some of the challenges and barriers she expressed. Also, I, more so, from the DC Health perspective on the operations side, as well as thinking about a lot of the challenges that we've perceived have mostly been around really making sure that all collaborative stakeholders involved are clear on the focus of the collaborative and ensure there's a space for all of their voices to be heard. Exactly what you reiterated, Gayle. Everybody can't be involved. However, we want to be able to take them into account as they're all very important. They'll really aid in the success of the PQC. So giving priority attention to how to address underlying strategies without losing sight of our key focus, our clinical quality improvement. Some other barriers are related to consistent participation. So not only everybody wants to be involved and at the table, but there's been challenges around participants not being able to consistently attend. Understandably so, stakeholders are balancing many other projects in their day-to-day professional lives. One issue around that is just the time that it can take catching up members that are behind or might have missed meetings versus keeping the momentum of the PQC going.
Mm-hmm.
From the DC Health perspective, this is a common challenge across similar types of collaborators and committees. This isn't unique. Many of the ones we're involved with and we help support and lead. So this will continue to be appropriately and delicately addressed by the leadership team.
That's interesting. Yolette, what are your thoughts?
All right, well, I'm going to take this in the patient family voice perspective. We are very happy to have an incredible mom on the PQC who is not timid to share and provide insight to help create healthy outcomes for mothers, but she is currently alone. So to your point, Lindsay, with the consistent participation, so the barrier that I see there is not having more patient voices with scheduling conflict, of course, live events, we've had to re-strategize. And on the recruitment and retention process, we started with 3 moms and now we have 1. However, Gayle already mentioned the plan that we have with Healthy Start, working with Healthy Start, having that collaboration. I am hopeful that we'll be able to bring more patient voice and perspective in the work, and I think that's very important. So yes, that has been a barrier, but we do have a plan moving forward. So I'm very happy about that.
Yeah. Well, it's interesting you mentioned that, because I think one of the things that we heard from a few of the moms was, that the time, and it's not a huge time commitment, but when you're busy, sometimes it's tough, particularly if you have a new baby that you're taking care of along with the rest of your family. And I think, one of the things, I didn't say this in the going well, but one of the things that we've learned from our sort of sister PQCs, if you will, is that we're actually a little bit ahead of the game in involving the patient voice. A lot of PQCs did not start to think to include them until recently, and or did not involve them until they were much further down the road in terms of their activity. And we really felt like it was important to do that right from the beginning. So we're a little bit ahead there. I think the disadvantage of that is, as you could see, a lot of the initial work is operationalizing the activity. So it's not jumping right into the improvement work. It's building the infrastructure. And so I think, if I think about it from my perspective as a patient, if I'm thinking about, doing these things, and even as a quality improvement professional, like I want to jump to the improvement, like I want to jump to the solution. And so it's tough. I think on some level, I'm pleased that we're moving to a point now where we're moving into implementation. But Yolette, to your point, I think it's critical for us, if I'm developing an improvement to a discharge information packet or something information that's going to go to patients, we need patients to tell us whether we're on the right track, whether the language we're working makes sense, whether we're speaking in appropriate ways and respectfully, and all sorts of other things. And so we're looking forward to sort of this next phase with them in terms of a barrier. I'll also put my own 2 cents. I'm not going to dance around. Addressing systemic racism is going to be a lift. If it was easy, we wouldn't be here in this situation. And these are difficult conversations to have across the board. I could put under things that have gone well. The group is not afraid to talk about it. And even when we have awkward conversations, people are willing to be sort of patient and tolerant with one another so that they can get the issues out on the table and have the conversations that need to be had. But I think that's going to be tough. Going forward, we're going to have to really sort of make sure that we're not losing track of that goal. And I'm pleased to see that the group came up with, that as sort of a separate goal, not just as sort of a nod on the side with another goal, because I think that's going to be something that we're really going to have to tackle, and it's not going to be easy. Let me move to that, because I sort of talked a little bit about a couple next steps. maybe we can pop to what do some folks see as next steps for the group? And then I can answer. We have a couple more questions that have come up through the chat. So let's talk about what you see as the most important next steps. You don't have to laundry list all the next steps that are on the list, but maybe some of the most important ones. And Lindsay, let me start with you from the DC Health perspective.
Great, thanks, Gayle. Yeah, at this point in the PQC process, the data collection and reporting cycle has been launched. So this is where we are, and this is an exciting and an essential point in the implementation of the PQC. So these activities are really what will drive the next phase of the intervention to be, implementing these data-informed quality improvement activities. Focusing on, for example, starting to identify gaps in identification and treatment of maternal hypertension among community members and hospital leaders. And also, Yolette has, spoken to this and, focuses on this area, but just, expanding the patient and family engagement piece, as we've talked about. And this will be a continued priority of the group. And one, we've mentioned Healthy Start being a really integral program in that effort and bringing in community members.
Great, thanks. Dr. Fries, what about from your perspective? What are you seeing as the most important next steps?
I really think that it will be vital to our own understanding as a group as we implement our hypertension bundle and then start to track the data, because that will give us a fundamental understanding of how data systems and how hospital-based actions can actually take place and be measured. It's nothing like doing the job and then checking it out to give you a clue on how you can do other jobs. So I feel like that is going to be one of our real formative actions. I think it will also help us understand too how we as a group need to engage outside the hospital basis and how we need to inform the community of women and their families in the district on healthcare between pregnancies and how that may impact, particularly in the aspect of hypertension, how that may impact their future pregnancies as well as their long-term health care. So I see that both as a very narrow focus. Okay, let's look and see how we do with our new AIM bundle now, but then how can we then take this information and move it to the community so it's not just what happens in the hospital, but it's what happens in between the hospitals.
And to that point about sort of in between the hospitals, the community perspective and the patient perspective, Yolette, what do you see as the most important next steps?
For me, I mentioned the mapping task force, and as they are looking at the work, the gaps and the resources that are available, one of the tasks ahead is to make some recommendations to the full group. But I think beyond making those recommendations is to identify where there can be some wins. And I know that they are already exploring options, looking at a guide to help individuals navigate and access many resources that exist in the district. So that's one thing. And then toward the equity piece, the health equity piece, I know we have many trainings on the way, and I think those are very important as well to as next step as we move forward with this work.
Yeah, good point. A bit of the sort of more concrete, I mentioned that the hospital teams have already started meeting. All 5 birthing hospitals in the city are engaged and not just lip service, but really engaged in this process. They have teams of nurses, physicians, quality improvement professionals, data folks, and sort of are really starting to dig into how do we do this actual quality improvement work and evaluating where they are and planning their next steps. Yolette mentioned the mapping task force and some of the other things, so I won't reiterate that. And you mentioned the training. We have a big a set of sort of training and implementation things that are planned and some activities around those, particularly around the health equity and disparities space, and identifying biases, addressing them both on an individual and a systemic level, identifying microaggressions and how they can impact people, and then sort of also transitioning that to, so I've got the individual concept from my actions and perhaps the actions of those that I work with. How do I make systemic change as a result of that? How do I make change both individually, and then how do I move the needle on that from a systemic perspective? If I'm talking about policies or big picture action items, how do I become sort of an advocate for those things as a leader within my organization to help move that forward? And of course, Yolette, as we've reiterated throughout, the key patient voice in that, and making sure we're including that and not just giving feedback, but actually actively involved in helping us navigate that space, I think will be a critical next step. To that end, somebody did actually, there's a couple questions in here, one of which is sort of related to that. One's if my hospital is implementing a bundle, can the PQC provide funding for materials to implement it? There is some funding for that, and we're constantly looking for other funding, both for the hospitals and if we identify other folks that we would want to work with, mechanisms by which, as things are identified as needs, that we're able to do it. If we're talking hypertension and there's a need for blood pressure cuffs of the right size, let's figure out how we do that. So some of it's sort of clinical action and some of it's materials. And so we're working through that now with the hospitals and with the groups about what's needed and then thinking through how we might do that. And I jotted down the name because every hospital is involved. So I want to make sure we're connecting you if you're interested in this, if you're not already part of the team. Someone asked about whether or not we have patient educators doing the teaching for the mothers concerning the health. And it's interesting you mentioned that. We do actually, we've connected with the Primary Care Association and a lot of the work that they've done to have some local expertise in terms of the health disparities and health equity education. And that is driven by moms and community members. And we'd like to continue to follow that model. Specifically, the PQC itself is about sort of providing the guidance around improvement. So the PQC might not necessarily provide the education to moms themselves, but we would want to provide education to the people who would provide the education, or resources to the people who would provide the education to do that, which could include patient educators. I think that's a great idea. Dr. Fries, do you know, from your perspective, if the hospitals or yours or others in particular may be using patient educators or peers to do some of the education from a clinical perspective that I might not be aware of?
It's a great idea. We have not utilized peer education as much at my own particular hospital. We have a very active group of nurses and social service personnel and providers, as well as, the whole team that is there in a hospital that fundamentally works for patient education. Although the concern that I always have is, are we speaking in the right language, both structurally in terms of the language, but also in terms of the language that connects with the patient? Because there's always the terrible hierarchies that are perceived. So the answer to that is, bottom line, no, not in terms of patient peer educators, but yes, in terms of active education, just making sure that it's actually giving the patients what they need.
Yeah, thanks. We love that idea. Someone asked about, based on the information we provided, what are the child development concerns we've identified and the information that we've identified there. The mapping committee may have delved into that a little bit. The initial focus of the collaborative has been on moms and trying to sort of get the quality improvement from that hospital scope up and running, and then sort of looking to that mapping group to identify where other activities would be involved, potentially even around, child development concerns and those kinds of things. And the PQC itself sort of has a work plan outlined, both required for the funding that so DC Health can make sure we're staying on track, but also because we need to know where we're going and make sure that we're staying on track for that. And part of that plan includes looking to expand from just moms to including moms and infants in a future year, but not in this immediate timeframe. But the mapping committee may actually identify some areas around child development that would be critical. There are other groups within DC Health that are looking at child development as well, and I'm sure would be interested in working with us, some of which are actually on our committee, and we've had some discussions with them, but nothing specific at this point because we're focused on moms as our initial group. And then someone asked about AIM and considering, is it, in terms of community voice of inclusion, have AIM considered a community-based committee, consisting of community members, patients, health system, et cetera. From AIM perspective, they do have a variety of different ways that they get input. I'd have to check with them to see if they actually have a community-based committee. I know that they've started looking at expanding with the PQCs that they support, some of that community-based activity. We do have that community and patient representation on our PQC full committee and our advisory board, and we have the patient family sort of action network committee that we had and are going to reinvigorate with some of this new work that we're doing going forward to make sure that we actually have a sort of a group that can be involved in that activity and both support one another and support the activity of the group.
Gayle, if I could add to that, under the 5th R for respectful care for that, the incorporation of patients as part of debriefs and family explanations, those are critical pieces for us to ensure. And so the development of both support as well as educational materials, as well as just engagement with patients and families is a critical part of that bundle.
Mm-hmm. Thanks, Dr. Fries. That's a good point. To that, we have just a couple minutes left. So I'm going to go through my panel and allow each of you, if you could go a minute, 60 seconds of sort of what thoughts do you want to leave us with? Yolette, let me just start with you on that, sort of key takeaways or thoughts you might have for folks in the audience.
Thank you, Gayle. Thank you so much. Well, for me, this work is not just work. I just want to leave that. I am a mom and I have 2 little girls, and I think it's very important for us to look at the health, the maternal health space and making sure that we do focus on how we can involve all community members to come together and make that change. We talk, we've had a lot of conversation, but I think it's time for us to also look at where we can put some action behind all the conversation that we've been having to make sure that future moms have better outcomes than the past. So I'm excited about this work, and I just want to thank everyone on this panel. It was really a great being on this panel with you all this afternoon. Thank you so much.
Thanks. Dr. Fries, let me let you give just a few seconds of sort of final words.
Thanks so much. And again, I echo Yolette that this has been a privilege to be part of this summit, but also to be part of this group. And for me, it's a profound honor to be working with such a team of excited and dedicated professionals in the development of the PQC. I also see that it is really vital for us to look at each of ourselves in terms of our healthcare provision with a vision to how we are truly engaging our patient and how are we understanding her and her family and her place in her community as a whole overall picture for her health care. I don't think that what we do in a hospital setting is enough to make a real difference for healthcare unless we overall look past that. And I think that's going to require all of us to recognize that when we provide healthcare, it's not just one moment, it's a perspective in a patient's life. And that's one of the learning things that we can bring from the Perinatal Quality Collaborative. Thanks so much.
Yeah. I'll do just 2 cents, just as I'll echo what folks have said here. So excited to be a part of this, so encouraged by it, and I'm ready for action. Not that we haven't done action so far, but I'd really like to start moving to sort of seeing some measurable results. And one of them, somebody asked a question about a website. We actually have a website developed and it'll be released shortly, but it's not available now. And we'll work to get the news out on that once it's launched. And Lindsay is the DC Health representative. I'll give you the last word.
Sure. Thank you so much, Gayle. I know it's 2:45, so I won't make this too long, but Dr. Freeze, Gayle, Yolette, completely echo what all three of you are sharing. As Gayle said, I've recently been to be a part of this project, and I'm very pleased to be able to have gotten caught up on all the great work that has happened so far and really learn where we're going forward. And as Gayle said, we're at the point where we're moving to this data-informed piece, which is really the meat and the crux of the PQC. So I look forward into kind of delving into that piece and thinking through the sustainability of the PQC long term and how we can sustain it, the culture and just the institutional best practices that we develop and learn for the PQC. So thank you to this wonderful panel, and I'm pleased to be a part of it.
Great. Thanks to my panelists, to our audience. We appreciate you allowing us to go on this venture with you.